So my name is Gerard Green. I'm a pelvic health physiotherapist in the UK, in Birmingham. And we are here on the start of July, 9th of July. And it gives me huge pleasure to spend some time and speak with Munira Hudani from Canada. And we have kind of used COVID-19 to kind of really connect. And I think it's safe to say that we connected initially on Instagram, where Munira does quite incredible both public-facing and clinician-based kind of work, particularly around rectus diastasis and other pelvic health issues. And Munira was based in Toronto, but she's now just relocated to Alberta. And previously she has been a director of a pelvic health clinic in Toronto, and she also works with the Pelvic Health Solutions Group in Toronto, which is Nellie Fagani, which many people will know. But one of her passions is rectus diastasis, and she has produced just phenomenally powerful material to both for clinicians and particularly for patients. And I'd like to, before we ask Munira some questions, I'd like to just thank her for the material that she produced for us, particularly in the Women's Health Physiotherapy Facebook group. And normally when we post something, we do get a good response, but we had a phenomenal response from your work. It was quite incredible. It was just, I think I posted one night before I went to bed, and then when I woke up in the morning, it was like 50, 60, 70 comments. It was quite phenomenal. So a really big thank you for giving up your time. And I suppose my first question for you is, where does your passion and interest in diastasis come from?
Well, okay. Well, first of all, thank you so much for even having me on and inviting me to collaborate with you, Gerard. It is such a pleasure to be here, and I'm very grateful for the opportunity. So thank you for that. My passion for diastasis. Well, initially, I entered the world of pelvic health pretty early on in my career. But at that point, I was sort of dabbling in the different realms of pelvic physiotherapy, seeing male patients, female patients, simple cases of incontinence and prolapse to more complex cases like chronic pain. But I started to have more of an uptake of and seeing more women who were prenatal. And I really was drawn to that. I was really interested in helping women who were in their pregnancy, and just the fact or the thought of me being able to help them in a positive way to potentially positively influence their delivery, that to me was really motivating. And so naturally, because I started seeing a lot more women that were in that prenatal period, I was also then seeing them postpartum. And of course, aside from pelvic floor conditions and their concerns for the pelvic floor, every one of them were saying things like, I feel so weak in my core. What can I do for my core? I really don't like the way my core looks. My stomach is still hanging out. I feel so disconnected. It feels so hollow down there. And so really, yes, there was a pelvic floor concern, but it seemed like at the forefront was more of a concern of their abdomen and the core. And so I was naturally inclined to learn as much as I could about diastasis and what I could do to help. And so at that time, though, when I started seeing more women that were prenatal and postnatal, that was sort of when there was also a rise in awareness of diastasis, and there was a lot of information at that point that was starting to be delivered in the online world, and it was they were all delivering a very consistent message about diastasis. The message being, be very cautious about what you do. Take a lot of caution and precaution over the movements that you do and the kinds of exercises that you do, because you don't want to make anything worse. So this was the approach that I was sort of following initially, and it was also the approach that I was teaching as well. And also, even before that, I had learned about like the Julie Tupler technique and the Noble technique. So Noble technique was where you take the scarf, wrap it around your abdomen, and
Yeah.
blended crunches. And the Tupler technique was more about the transverse abdominis and like pulling in the core and the abdominal wall and just doing thousands of repetitions of TA work. So I realized there were some flaws and issues with both of these approaches, and then the messages that we were hearing and reading up online, it just, a lot of it was very much based in fear.
So
And I
quite negative messages.
100%. I was recognizing this, that I was perpetuating that with my patients. And I realized that early on, and I knew that I didn't like that, and I wanted to find a different way. So in my own quest of trying to figure things out, because in taking what I'd learned and implementing it with my patients, I also realized that not everything was working. Some patients were getting better and some weren't, and many weren't getting better to the degree that they were hoping for and to the degree that I was thinking I was going to achieve with them. So like, all of this sort of pushed me into trying to figure out a better way to help women who, or individuals who have issues and dysfunctions and weakness with their core. And that's kind of where, you know, along the way I had kind of learned things and tweaked how I saw things and tweaked my own conceptualization of what I was working with. And these various tweaks to my approach kind of led to a very different approach today that I'm doing that is compared to what I was doing before. And over time, that's now has led me to kind of be in places like this and being able to collaborate and share this information so that it could potentially help more practitioners and therefore help more people who are having issues with their core.
And I think from you know, listening to some of your conversations that you've done with other people online, and obviously reading the guide that you put together for us, you move very much to what women can do.
Yes.
And a very functional approach, a very abdominal approach rather than a very much linea alba approach. So do you want to talk to us maybe about some of the key parts of that concept?
Sure. So the approach that I am sort of using right now, and it is always evolving, this is kind of where I'm at right now, and is one where the linea alba is considered as part of the broader context of the abdominal wall. So it's part of the core, but it's not the single focus of rehab and in me trying to affect the size of this linea alba. It's more of an approach of understanding that it is something that relies on the muscles around it for us to be able to influence it. And so if what we are doing is more tapped into the muscle system, which is really where we have a role here as physiotherapists in strengthening the muscles, we actually can then load the linea alba through the muscle system, and that loading then positively influences the linea alba. So not only does it benefit the muscles, the very weak muscles that we're often dealing with in the postpartum period, but that in and of itself is what then directs the change into towards the linea alba. So it's sort of changing the way you're seeing it, but also coming at it from a different angle, rather than directly looking at the linea alba and saying, what can I do directly to this structure? It's coming at it more indirectly from the structures that actually influence it. And so the benefit that I've seen with taking more of this larger abdominal wall context and approach is that we end up focusing again on the strengthening aspect of it, which we know how to do well as physios. And that then translates into like to our patients, who are then able to overcome the various fears of movement that they've picked up along the way from what they've read online or things that they've been told, because in our strengthening process and our strengthening exercises and program, they're able to see how much they're able to do, and to go from one simple exercise to a little bit more of a harder version to a harder version to they start paying attention to the progress along the way. They start paying attention to the improvements that they're making in their core. And that in and of itself is a very powerful journey for someone to experience and to be on, because that is what allows them to feel like they're becoming more whole again. They're coming into us feeling broken. And once we start showing to them, you can do a lot. Look, last week you were just doing a plank on the wall, and now you're doing a plank on the ground, a full plank. They can really start to feel capable again. So that came down to the strengthening exercises. That came down to us not limiting what they can do, and us instead of following certain ideas of which exercises are good and bad. It's more about looking at the individual in front of us and assessing what they can do.
So
And
it's a real shift in focus from that very gap-centric approach. Is it changing? Is it getting smaller? To really setting those goals, like, you know, you could do this exercise when I saw you 3 weeks ago. Now you're doing some exercise in weight bearing or lunging or squatting. So kind of using that as progress rather than just having those women quite overly focused on what that gap what the width of that gap is.
Yes, and the reason why I think we want to set that out as one of our goals at the beginning of our interactions with our patients is because linea alba is connective tissue, and connective tissue takes time to change. It doesn't happen overnight. Muscles become stronger at a much faster rate than the time it takes for connective tissue to change. So if we are simply looking at the linea alba and going back to that to measure, has there been any change? Has there been any kind of influence in our program on the linea alba? Because it takes so much longer, we may be overlooking all the progress that they're making at the muscular level because we're simply not paying attention and we're just not capturing it. So they may be getting stronger and noticing these changes before they even see the changes in the linea alba.
Because we've got Yvonne Cauldron is one of our UK colleagues, and Yvonne's work kind of has highlighted that as well, her PhD, because it looked at the big changes in that anterior abdominal wall that these women go through. Whereas I think sometimes that's kind of been forgotten about because there's this maybe media-centric focus on that linea alba.
Yeah.
And in terms of when you assess these women, so I think what comes across in your work, which is what people are looking at now, is really maybe what tension is through those structures. So how do you assess that, and how do you, because it's a difficult thing to quantify, and it's quite subjective, but how do you do that?
Right. Yeah, and it is subjective for sure. But what we can do is we need to have some kind of reference point in order to compare tension anywhere along the linea alba to something else that maybe hasn't been as affected. And so it can be quite easily done in a clinical setting to measure tension. First of all, what we're talking about when we're talking about tension is simply the ability of the lateral abdominal muscles to sort of pull along the linea alba and therefore take up slack through it, and it then becomes a more firmer structure under palpation versus before it being tension, it feels a lot softer. So what we're trying to feel for is a change in palpable firmness under our fingers. And so what we can do is actually feel for that tension, feel for that softness or firmness along the length of the linea alba in comparison to the area that was least affected, which is right under the xiphoid process. So the linea alba that attaches to the xiphoid process is the least affected from pregnancy. And so we can use that as a comparison point, as a reference point. If we assume that this is maybe a 5 out of 5, if the tension and the quality of the tissue there is a 5 out of 5, we can then start assessing the rest of the linea alba and compare it to that and say, how much do we think, or would we agree that the tension in the supraumbilical region or the infraumbilical region is to the same level of integrity as the region beneath the xiphoid process. And we could say, okay, it feels very different, so maybe we would give it a score of 1 out of 5. Or
Right.
it feels very, very similar, so we would give it a score out of a 5 out of 5. And this is a measurement that I've taken from Sinead Dufour in Canada, who's
Yeah,
doing a lot
yeah.
of research on diastasis. So I thought that was a really, really helpful tool clinically that we can use, in addition to just feeling for that in a supine position, which is probably the best position to feel this tension when they're at rest, and compare it to that. We're also getting a sense of the depth in that
Yeah.
assessment as well. But then we can do the same thing and assess after they've actively contracted
Right.
their
So for the change.
exactly. And again, compare that to the top and scale that from 1 to 5 as well. So we can assess tension passively without the engagement. We can assess tension through the active engagement. And also we get the information that we need to better understand how the linea alba really sustained the stretching in pregnancy and how well it's recovering afterwards.
So do you tend to reassess that in terms of, well, what's the change in tension like with activation of transverse abdominis? What's the change in activation with contraction of pelvic floor? So adding in those activities.
Definitely. Yeah. I'm definitely, at least when I'm assessing my patients, I'm looking for if there is a change in tension from before they engaged to after they engaged. And that's because, as I was mentioning before, the way to influence the linea alba is through the muscle. So once we have felt a change at the linea alba because of the muscle contraction, we know we have now influenced it to some degree. The more slack that has been taken up, the more that structure is able to therefore transfer loads through it. And so loading is the primary foundation from which collagen synthesis occurs. You know, the linea alba and collagen will adapt according to the loads we place on it. So if we haven't taken up slack, if there hasn't been any change in what we're feeling after they've engaged, we may not be very effective in that particular exercise to change that linea alba.
So do you also repeat that in weight bearing?
Yes.
That palpation, that tension, that change in tension with adding in some of those other muscle groups?
Yes, you can definitely do that in weight bearing. And actually, that's usually where I start. So it's when they're standing and you're just kind of looking at the abdominal wall and kind of engaging what we're kind of dealing with at first. At that point, and I'm talking more virtually, and if we were in person, we can do the same thing. But after sort of assessing the amount of distension, which also might give you an idea of how much connective tissue laxity and thinning there may have been, but in standing, then you could simply feel along the linea alba before they have engaged anything, just to see if there's any areas that are feeling a bit more thin or softer. It is a bit harder to feel that difference from the different regions, lower to upper. It's a bit harder in standing, but what you can feel better is after they've engaged. You can feel a much better tensioning. It's much easier to feel that under palpation when you're doing that in standing. So you can just get them to engage in standing and feel and compare again to the xiphoid process.
So at the moment, here in the UK and in many other countries, lots of us are still seeing these women remotely.
Yes.
And so would it be so we try and get them to palpate tension.
Yeah.
So would it be of value to say to them most people can find the xiphisternum because a lot of people have been trained in CPR. Would it be a case of getting them to palpate below that and then into the linea alba and say, well, does it feel the same, softer, just as a bit of a reference point, that because they were doing some self-assessment?
Precisely. Precisely. Exactly how you can assess tension virtually is by getting them to compare the linea alba to a different part, like the region underneath the xiphoid process. Yeah.
And in terms of, say, the approach that you would have started out with, which would have been more of a pretty traditional approach,
Yeah.
and the more functional approach you have now, what are the differences you see in terms of how those women respond?
Okay. They're quite significant. In changing the approach, it has led to a much faster accomplishment of their goals and achievement of their goals. And whether that be functional in getting them to get back to running or yoga or CrossFit, they get there a lot faster because the emphasis is on the strengthening and building back up those muscles so that they can better tolerate the pressures involved in whatever activity they're trying to do. And through that, because through strengthening, we are also trying to follow the principle of progressive overload. So as we are progressively loading these tissues, that's when they start to adapt. And so the tissues, the connective tissue becomes a bit stiffer and thicker, more resilient through that process over time. And so what you end up seeing is that not only do they feel stronger, but the tone, the abdominal muscle tone, and the overall tone of the abdominal wall, it changes such that it starts to draw inwards. And actually
Right.
Most, if not all people who are coming in to see us, they really want to, they're very dissatisfied with how their core looks. So we're helping them to some degree with that sort of drawing in of the abdominal wall. And I would never say to them, this is what we're doing. I'm going to guarantee you that after this, I can get you to have a flat stomach again. But what we are working on is a strengthening process. And through strengthening, we're going to start seeing some of those changes occur. And so the results have been very, very significant. And it's happened very quickly. These things can happen very quickly where they start feeling that strength change very quickly. And then over time, that's when they start noticing the actual physical manifestations of that with how the abdominal wall looks.
Brilliant. And then I suppose that then gives confidence and more resilience and less anxiety, less stress, so better tissue healing, and they feel more confident to get back doing things.
Yes, exactly.
I think before we go into some of the questions, of which there are more, because people have just been adding in more this morning. So you mentioned the depth. So, yes. And that does tend to change because when you get kind of almost less tension. So how concerned are you with the kind of measuring that depth and looking for changes in depth, which tends to, suppose, go alongside changes in tension?
All of that, yeah. So depth is simply a tool that we're using to assess the integrity of the connective tissue. So depth is a way for us to understand the quality of the tissue that it is that we are dealing with. And so that's really one way of assessing it is through depth, but there are other ways as well. And that can be through tensioning. And that could also be through doming and how much doming occurs and their control over it. And so how concerned am I regarding depth? It is something that I pay attention to, but I use it as one thing to give me some information on the linea alba rather than the only thing. Because we're limited with that assessment in the position that we have to do it in. Depth is usually something we assess in the supine position, whereas depth is not something you can really noticeably assess in any other position. So in that regards, our ability to really feel changes in depth simply may reflect what we're doing outside of the supine position. So when we go back to that and start measuring it, we may notice that there has been a change in that tissue and therefore a change in the depth. But overall, when we are looking at depth, we will, if we start to see changes in it, it simply means that there has been a change in a response of the connective tissue system. And that can be also visible in other ways. So that can be through just abdominal circumference where things start to draw inwards, or through just the feeling of firmness, so that tension, just passive integrity. So depth is just one of those factors.
And I suppose I might be wrong here, but we don't seem to have really much normative data on depth anyways.
Right, okay, so it's great that depth was sort of our way into understanding that diastasis is more than just the size. So we had something else to look for, which was depth, and then there's the additional factor of tension. To my knowledge, there is no normative data on depth either. But again, if we're thinking of what depth serves what is the purpose that depth serves for us, it is to provide us some information on the quality of the connective tissue. And so while we don't have information from studies on what is considered a normal depth, it would likely be a more shallow groove.
Yeah.
What we are starting to have are some studies that are looking at something else for connective tissue, and that is an assessment of stiffness.
Right, yeah.
When we think of connective tissue, its role is to really resist tensile forces in our body and to provide some stability. It's a stabilizing element of the abdominal wall. So when we're looking at stiffness, the stiffer the connective tissue, the more efficiently load and forces can be transferred through it, and the more pressure and load the tissues can withstand. So stiffness is a very, very useful measure that is we're just starting to tap into the potential of stiffness to give us information in the research, because it has been shown that women who have diastasis and who do certain tasks like a curl-up task will present with less stiffness and more distortion in the linea alba than those who don't. And so and the thing with stiffness, which is really great, is that it's very easily measured and assessed and evaluated in a research setting, because we would use something like ultrasound elastography.
Yeah.
And it's been shown to be highly reliable and valid. So rather than depth, stiffness might be a better tool, especially in research, to quantify some degree of improvement, or just to give us some more measurements of the connective tissue.
So in terms of, because physios always want to know more, they always want to read more. So in terms of signposting and some of that research on stiffness, so apart from, say, the Paul Hodges, Diane Lee work, who are the other people that we could signpost people to?
So there was a study done by a group of Canadian researchers led by Nicole Hills in 2019. And I believe, okay, I don't have the exact.
Google finds everything.
Yeah, but I think it's something along the lines of comparison of stiffness of the linea alba between women with diastasis and women without, something like that. That's the title. And so it's a very fascinating read. And what I love, again, is that it's starting to take into account not just the size of the gap, it's about the quality of the tissue within the gap. And the quality of that tissue is present within the linea alba, but also potentially representative of the quality of tissue of the connective tissue of the abdominal wall, if we consider the linea alba as part of the abdominal wall. So if we consider the stiffness of the linea alba in addition to the stiffness of the abdominal wall connective tissues, such as the rectus sheaths, then I think we're going to start seeing some changes and differences being picked up in the research. regarding having potentially less stiffness, more compliance of the abdominal wall, and potentially dysfunction associated with that. Because right now it's kind of been hit or miss. If we're just looking at the size of the gap, and if that then leads to impairments like deficits in certain movements or weaknesses, it has been hit or miss. We haven't had very consistent studies that demonstrate that a change in gap or a larger gap results in certain movement impairments. We have had some. We have had a study that, or several studies that have shown or correlated a larger IRD with flexion impairments and rotation impairments. So it has been shown that women that have diastasis may have more weakness in these particular movements. But we always have to remember that correlation doesn't mean causation.
Yeah.
And it's hard to know if that was the result of a wider linea alba, or if it was the result of the tissue, the broader tissue, the global tissue that has been weakened and thinned out, and so not able to broadly transfer loads through it rather than just through the midpoint, or if there was simply weakness in the muscles themselves after pregnancy that have led to the weakness and the impairments and dysfunctions that we're seeing. So there's a lot more to consider. And because we have also seen, and we do have research that says that these muscles were impacted in pregnancy. Rectus abdominis was thinned and stretched out. And so postpartum, there are weaknesses that we see in the muscles. And also we see that there's a change in the interrecti distance, but that doesn't necessarily mean that the interrecti distance was the cause of the weakness.
Yep. So although we can't predict the future, do you feel that if there is maybe a shift in the outcome measures, which you've talked about, the tension, the ultrasound elastography, do you feel if there is a shift in some of the outcome measures away from the interrecti distance, that then there may be in the future some studies produced that look a bit more favorably on the role of rehab in the management of diastasis? Because at the minute, when you look at the literature, it doesn't jump out at you.
Yeah, it's very early in that sort of realm of research. It's very early to, these concepts of stiffness have just been brought out. Stiffness really was in 2019. The idea of distortion was in 2016 with Diane Lee. So we don't have a lot of that right now, but I do suspect that we're going to start looking at these things more in the future, especially since stiffness is easily measured. I think we can easily start to see then if that is more correlated to functional deficits and weaknesses and impairments that might show up, if there are correlations to that, and then potentially measure that against if those are also occurring in women with larger IRD, so we can see which one of these factors may have more of a role to play, whether it's more of the stiffness or if it's the size or maybe it's both. And also, again, stiffness of the abdominal wall, potentially the distension. We may not be noticing changes, we may not be noticing correlations to diastasis and things like pelvic floor dysfunction or diastasis and low back pain or pelvic girdle pain, simply because we might be looking at the wrong thing or looking at something that may not be what influences those particular conditions. So if we take a step back and potentially look at the whole abdominal wall, and what other things we could look at are, like, again, the laxity of the entire abdominal wall, we might then start picking up if something else can be contributing to these, and therefore our rehab programs can therefore then go in and start addressing some of the things that we're seeing in front of us. And so going back to the idea of connective tissue potentially, and the quality of the connective tissue, and the role of the connective tissue in transferring load, and how that could potentially have been impacted from pregnancy and remains like that after. If we're looking into that, then we could also be looking more into the rectus sheaths, because load gets transferred from the rectus sheaths before it even reaches into the linea alba. So we have some studies that are looking at how pregnancy affects the rectus sheaths, and it has been shown more that it tends to really negatively impact the posterior rectus sheath more than the anterior sheath. There may be a line of research going into also the linea semilunaris on the side, on the lateral border of the rectus abdominis. And so that particular junction, let's say if we're talking about the posterior rectus sheath, okay, and the point from which it comes from the transverse abdominis, that junction right there is part of the linea semilunaris, and that distance from the medial border of the transverse abdominis to the linea alba, which is the posterior rectus sheath, that could potentially change and lengthen more in pregnancy and could stay like that postpartum. So having some kind of measurement of that could also be a way of understanding what we need to work on, and if that also leads to some issues in the postpartum core. And so we also are probably going to start seeing studies that look more into how we can best address these issues in weakening of the connective tissue. So how can we best load the tissues? What are the best strategies for that? So with strengthening and conditioning style research studies. So there's a lot of potential here for where research can go. And I think over time it will shift away from interrecti distance to some of these other factors instead.
And it does look like there's a real concentration of that in Canada, which seems to stand out.
Right.
So it's Canada and Scandinavia. So,
Yeah.
So we're trying to shift clinicians away from the interrecti distance. So how do we shift the patients away from, how do we shift these women from a real focus on the gap?
That is probably the golden question, and that is probably the most difficult thing, because we're battling against the information that's online and the overabundance of this information that is, like I said, very consistent across the board in what it tells women what they can do and what they can't do. So right now, what we almost need is an overwrite of that, with more voices going out there and sort of overriding that information with other positive and function-based information and evidence-supported information. So how do we shift that in our patients? Well, I think we do our best by explaining to them that really, if the goal is for them to close their gap, if that is why they're here and seeing us, that even the top researchers in the world don't know how to do that. And so we may be misled right now just from all the information that's out there online to believe that this is something we can do, because there are promising programs of do this and in 12 weeks you'll have your six-pack back and you'll have your gap closed. But if you just take those programs with a grain of salt, in knowing that even the top researchers who are in the field don't really have consistent ideas of how to do this, that if the goal is to reduce the gap so that they can go back to yoga, CrossFit, running, what have you, then actually having a wider linea alba is not going to prevent you from going back and doing those things, because there are a lot of people with training and strengthening who still have a wider linea alba and can go back and do those things in just a matter of time. So the size of the linea alba won't determine what you're capable of doing.
Yeah. And I think the women we see, they may initially come to clinic focusing on the gap, but I think really they're focused on what that abdomen looks like. And as that tension improves, the co-contraction improves, it looks better, it's stronger. So I suppose it's maybe shifting them, that it's not purely about the gap, but if they do all this, it will they'll be stronger, it will look better, because they want it to look better. They want it. It's an important.
100%. Yeah, 100%. And I think it's important to let them know also that the way to get there, to look better, to improve its appearance, isn't through reducing gap size. It's through improving the status of the tissues and the muscles around it. And that then could potentially influence the size of the gap. So, and also that there are many women who have flat abdomens with a wide gap. So that just to sort of dispel those myths right at the beginning, that having a wider gap doesn't mean that you're not going to have a more pulled in and toned abdomen. It's not related that way.
No, the good news is we've worked through lots of the questions as we've talked, so that's good.
Right.
But we have some more, and I'd like to just thank all the people who took the time to post a question, whether that was on. We've had mostly via Facebook, but we've also had some on Instagram and Twitter. So a big thank you, because it's that's really appreciated. And one question, I'm gonna ask one of my questions, and that's really, so here in the UK and in many countries, women tend to seek help via Google.
Right, Dr. Google.
Mini Google. And what tends to come up probably is more the postnatal trainers.
Right.
Physios just aren't brilliant at marketing. So what would help say that, you know, postnatal physio specialist stand out? So what can they offer these women that's kind of unique to what we can do?
Well, in terms of the pelvic floor world, we have first the most direct ability to assess the pelvic floor than, let's say, a personal trainer. But I think the reason why maybe the trainers are standing out as the maybe go-to profession to get help with their core is because they're doing a pretty good job online in putting the information out there. So like I was saying before, I think if we as physios collectively start producing content that we are passionate about, and some of us might be about diastasis, or some other people might be more interested in incontinence or chronic pain or what have you. If we just start putting out the information ourselves, because we are more of a medical profession, and so we tend to practice based on the information from evidence that we have. So if we start putting out this evidence-supported information, and the more numbers we have in doing this, the more we can kind of sort of climb up to the rankings of, let's say, the personal trainers that are doing a really good job in getting their message out there. I think we just have to passionately deliver our message as well. So
I think that's what's brilliant about you. I think that's what's brilliant about what you produce, because it's very visual. It draws people in. It's visual. It's got stunning kind of graphics, but it's got very succinct messages.
Yeah.
I think sometimes when we as physios produce material, we maybe subconsciously feel we've got to produce it for other physios who might be critiquing it, and, you know, as opposed to producing it for the public. Like, so I think if I would really encourage people who are listening to find Munira on Instagram. So it's at Munira PT, or is that Munira Hudani PT?
Yes.
And it is striking. You know, it's really powerful graphics, both for clinicians but also for patients, which I think that's really important.
Yes, yeah. So I do try to really provide the content in a way that is easily digested from both sides, from the patients and from the professionals. But I'll just make a really quick point here in that I do find that trainers and those in the fitness industry do look to the physiotherapist for information. And so when we do go out there and provide information, they do tend to start listening to what we say, and therefore there's opportunities for more collaboration. I've collaborated with a number of trainers, and they very often recommend physiotherapists and their clients to see a pelvic physiotherapist right away. So just forming collaborations and building relationships and consistently putting out information online in a way that is authentic to you, because maybe I'm doing more visual stuff, but that is not how everybody likes to make information. So in a way that makes sense for you, whether that's now through TikTok and all those fun videos that we're seeing.
That makes me nervous.
I know. Like, you just master one thing and then there's a whole other thing that comes out.
Because what we've done in the clinic, particularly around diastasis pelvic, is we've done joint clinics. So we've done a joint clinic where myself and one of our brilliant postnatal trainers, Kerry, or one of our brilliant postnatal trainers, Mandy. So we will see patients together, and women love that. So we will do, yes. When we did the last one we did, I did the ultrasound, then they did some of the functional tests. It was brilliant. It was brilliant.
Yes.
Now, we've got some questions which just came in today. So I'll rapidly throw these at you. So, is it ever too late to effect change?
No. The short and sweet answer is no, it is never too late. Just like it is never too late to go start working out. You're never too old to begin strengthening your body.
And that's a good analogy. That's a powerful analogy. Is there any evidence for wearing a support or tubey grip?
There is limited evidence to support the idea of wearing it in reducing the size of the gap. But if we just maybe clinically reason as to why we're using an abdominal support or a tubey grip, if that is to provide support to the abdominal wall in a, if it is in more of a weakened state, then in a short period of time, or in the interim of as getting the muscle stronger, the support externally can help and can certainly help them feel more comfortable. So the evidence isn't there to say that, but we can use it just like we use support around an ankle that might need a little bit of that compression after a sprain. We can certainly use that in the immediate postpartum period for certain individuals.
Then another question, which I think I may be able to answer, is what's the specificity and sensitivity of the tests used to measure a DRA? So I suppose what people may be referring to there is the interecti distance, which we're obviously moving away from. But I think diagnostic ultrasound has good sensitivity and specificity. It's got good reliability, but that is solely for measuring the interecti distance rather than, I think, the work of Hodges and Lee looked at tension, but that's not something we can translate into clinical practice because we don't have those algorithms to do that, but maybe in time we will. And then another question is there a difference in prognosis if the diastasis is above or below the umbilicus?
Oh, okay. That's an interesting question. Is there a difference in prognosis? I don't think it's location specific. I think it's what is happening at the location. If there is more stretching and a wider linea alba above the umbilicus versus below, then that will likely be the region that takes longest to recover and the longest to change and influence, versus if there is a region that is wider below the umbilicus. I'm still not sure if that will be any different than at the top. The one thing that I can certainly say is that the anatomy is different in the lower abdominal region. We don't know how that plays out in recovery. I have seen, I mean, I'm sure you've seen the study about those who had participated in a running program, and it actually helped to reduce the size of the gap. And that was more prominent in the lower abdominal region versus the other two regions that they had measured above the umbilicus or at the umbilicus. So there may be a role in that change in anatomy where all the rectus sheaths become more anterior versus being split, the rectus sheath going behind and anterior to the rectus abdominis, where all of them now go anterior to the rectus abdominis. There may be something to that changes how
Right.
that region responds to treatment. We're just not sure yet.
And then just two questions. Like here in the UK, we don't really have too many women who go for surgery.
Okay.
Is that something that you've seen much of?
I have certainly seen women who've gone for surgery, and have certainly seen women who have come to see me for other reasons. And in part of our history, they had revealed that they had had a tummy tuck or an abdominoplasty before. But it's not I think a lot of, I don't think it's something that people are shying away from. I think they recognize that there is the role for surgery. What I'm starting to see, though, is that there is also this fear around surgery, and we sort of vilify it as something that should be avoided at all costs. And there's a phrase that Brianna Battles had used, which I loved, and it's, although surgery is the last option, it's not the worst option.
Right, okay.
So just understanding that there is a place and a time for surgery, and it is sometimes what is needed for those people to reach the goals that they're hoping to reach.
And then the last question is, as we are, most of the people listening to this will either be physiotherapists or specialist postnatal trainers, and you've talked a lot about exercise and the importance of exercise. So what are your kind of top kind of 3 exercises you do with these women?
Oh,
I'm mindful that it will depend upon.
That's a loaded question.
Like. Yeah.
I would not say that there's a top 3, but I would say there's more of like a systematic approach to loading that I use depending on who's in front of me.
Right.
But I usually would start off with just making sure that they have an understanding of what their pelvic floor is and their TA is and their breath. And then after they've learned how to use those muscles and contract them, then getting them to coordinate. And then after that, I begin loading and adding progressively more and more challenging exercises so that they're able to get the strengthening process underway. But also I'm watching for things like, are they doming, but how much doming are they producing, and do they have control over that? So while I'm loading, I'm also just looking for certain benchmarks to make sure that they're managing pressure well. That being said, once they're able to coordinate, I would then, I guess my go-to first step, or maybe second step, the first step is all that I just mentioned. The second step is, okay, once they're able to coordinate it all, I tend to go towards forwards leaning and backwards leaning in upright positions. I tend not to do a lot in the supine position. So if they're able to draw in the abdominal wall, let's say they inhale and release and exhale and engage the pelvic floor and draw in the TA and the abdominal wall, can they then start sustaining that contraction and holding it, not just as they're standing, but as they're leaning back, sitting down, and as they're leaning back, and can they hold that there? Because it becomes more challenging to hold themselves upright, and so it becomes more of a core challenge. I start doing things like that, and then getting them to take their TA through the full range of motion, and then I also simultaneously will add exercises that progressively load them more front facing. So starting at a wall, just in a modified plank at the wall, doing some of these contractions through there, and then gradually lowering down until they're now parallel to the ground, doing a plank, and doing that breathing coordinated and pulling everything in and releasing it and controlling it. So I tend to start with that, but then I continue to add rotation exercises. That could be done quite easily through TheraBand work, and you can start with like the Palloff press, and then you can start adding rotation through that, and those again are done in upright positions, and then you can start adding more diagonal movements. So I tend to add rotation, upright exercises, a variety of exercises, so that if one exercise doesn't quite tension well or doesn't work the rectus abdominis as much as I would like it to, or if it doesn't work the obliques or the TA, that there are other exercises that do. So in the
Yeah.
program that they have, they kind of are able to get the best out of it.
And I think what I loved about the document you did for us is that it's kind of like on, you know, it's that there aren't any wrong exercises. Or there aren't any banned exercises. Well, I don't think you use the word banned. There aren't any wrong exercise, but it's the right exercise at the right time. Now, what I'd like to do just for a moment is just highlight where people can find you, because I do feel your stuff is just powerful. So here we've got Munira's Instagram page, and we've just got some really, really just striking kind of images and information there, and in it just draws you in. You look at these and you think they jump out at you. I want to read those. And then there's also some really brilliant stuff on her website, and I would really recommend. Do you do anything on YouTube?
Not yet.
Not yet.
One thing at a time.
Yeah, that's true. Yeah. The Instagram is amazing. And so what I would like to do is we could kind of keep talking forever. What I'd like to say is just a huge thank you to you for all the work you do for our physiotherapy community, and your work kind of really promotes physiotherapy particularly for diastasis, and that helps women get help no matter whether they're locally in Canada or whether they're in the UK or wherever. And a big thank you for the guide you put together, because it is powerful. Thank you for today, and I'd like to just thank all the people who also supported the interview by taking the time to send us questions, which we've kind of weaved in. So just a big thank you, and it's been a real pleasure and highlight to meet you over lockdown. As I said, it's been one of my lockdown highlights, really, connecting with you. And thank you for today. Thank you for today.
Wow. Well, thank you so much for inviting me on, and I really appreciate this opportunity, and that appreciation is mutual, and this is also a highlight for me too, so I'm very grateful to have been here. And if anybody does want more information, they can go to my website. That free guide, I believe, is on the Women's Physiotherapy Facebook group, and also I've made a link available on my website, so if they haven't quite gotten the guide yet, there are a couple of ways to get it.
Yeah, and what I'll do is when I post the recording, I will post the link to the guide from your website, because then people can share it and their patients can avail of it. So big thank you, and enjoy the rest of your day in Canada.